14th, 2021. This is a special meeting. July 14, 2021. The time is 1:03 p.m. Special meeting agenda to discuss our fiscal year 22 health insurance with our guests from Alliant and attending our commissioners Duncan Brooks and Filios. Do we have any changes to the agenda? Hearing none, so we welcome Scott Burkhart, Coco Bakoff, and Dave Smith from Alliant. Thank you all. Welcome. It's great to see you again. And without any further ado, take it away, Scott.
Great. Thank you. I'm going to have David Smith start it off with the numbers, and then we'll get to some options and recommendations.
Push your button there.
You want me to say
There you
that?
go.
We'll have David Smith start with some numbers, and then we'll get to some options and recommendations. So.
All right. First, let's take a look at how we're doing so far, and this is the performance to budget. So we're certainly looking at October through September. Now we have 8 months of data in the time frame, which is data through May. June, just so you guys know, would just now be coming available sometime this week, and so when we schedule a meeting this time, we're always going to be just a little bit behind. But I expect it's going to support the numbers where we are. We're going to start with the 2021 projected, and we turn that into the first 8 months. So what does that 1 year projection look like over 8 months, and how does that compare to how we're actually doing? And you can see that we're a little bit ahead of schedule, about a $341,000 gain compared to what the projection was. That's almost entirely in the medical plan. And there's a lot of reasons for that. We still haven't gotten back to full speed yet as far as everyone accessing healthcare the same way. There was a little bit of hole there. That hole varies based on region. So if you go over to friends in Washington State, they have a bigger hole in the data because they were shut down longer and people weren't accessing care for longer than over here. But there's still a hole, not just because some providers didn't have the same hours, but there was also people in any area who are more trepidatious and aren't necessarily seeking care and kind of waiting this thing out a little bit. And so you'll see some of that come back. But we are at a $341,000 gain in total for the year, even though we've increased in enrollment compared to our projections. And the big one there you can see is the medical is 1.6% higher. That's always going to be an issue because when we project, we're projecting a total dollar amount. But when we add employees and we get a little bit bigger, that can have an impact, and you'll see that when we look at the projections. Move on to the next slide. So looking at the history, I thought it'd be good because we haven't really gone over this, I don't think, in any of the recent meetings, and a more extended history of how that plan is performed and how you've changed over time. And so you can see your employee growth. You're about 70 employees larger than you were in 2017 compared to now. If you look at the 2017 through 2020, and you look at the percentages down below, you have the total cost growth, and then you have the enrollment growth, and you have a PEPM growth, which is that's per employee per month. What we're really looking at there is to say, because 2021 is not yet complete, how do we make a comparison? Well, if we look at a per employee per month cost, that's how you do the comparison with the differing time frames. And we had the big increase in 2018, and the question was always then probably, is that a blip or is that a new level? It looks like that was a new level because we've not really gone down since then. But we have remained relatively flat from a per employee per month standpoint. Most of the growth in expense has come because we've had more employees rather than per unit cost growing significantly. And so that's some good news. That might be a reflection of the underlying population. When you hire new employees, you tend to end up hiring younger usually. That's often what happens. And so that changes your workforce base. They cost a little bit less. That's not always the case. But that's the situation you have. So it's pretty good performance other than, that 2018 compared to 2017. Relatively flat. So then we look at the renewal. And really broken this down into 4 primary categories, which is the medical plan, dental plan, vision, and miscellaneous, which would be any of the admin fees, running any of the systems, LTD, short-term disability, life AD&D, any of that ancillary lines of coverage that you have. And our projection for 2022 is a 3.8% increase on the medical over the 2021 projection, a 5.6% increase for the dental over the projection for 2021, 11.3% increase for the vision, and a slight decrease on the miscellaneous. And there's a lot that's driving that, so go ahead and click. One of the other things that we need to consider, because we're at a 3.8% increase overall, is if the employees, the employees pay contributions in their paychecks, right? Every other paycheck, there's an amount that goes in. When we take that out, if we assume that they did not increase, so your cost increases, but their cost doesn't increase, it means your share of the cost would increase by 4.6%. So it's good to know, both of those numbers. Go ahead and click again. What's driving part of that then is you have to also consider that the enrollment in our projection is growing on the medical plan by 1.3% to kind of catch up to where you are. We're not anticipating additional growth this year. Maybe that'll be different. You'll tell me something different. But the reality is we're not anticipating further growth from where you are. And so that 1.3% growth has an impact because we're showing more employees. And so when we look at that 3.8 or the 4.6, the number is actually lower if you look at it on a per employee basis. Go ahead and click. And so, actually it's higher. With the enrollment growth, sorry, I get confused sometimes. So with the enrollment growth, that 3.8 and the 4.6 becomes 5.3 and 6.0. And so those are real starting points. The 5.3% total 6.0 if the employees don't pick up any share of the cost. And that always depends on how you perceive or look at the cost share. Some people look at the cost share as it's a flat dollar amount. I'm paying $120. Some people look at it as a percentage of the rate, and naturally it would grow up to the same point. So you can get an idea on what your strategy is on how you view that, whether you're looking at a 5.3% starting point or a 6.0% starting point. Good, Coco. But one thing I want to be clear on is how does this translate into actual rate action? Okay, because we're looking at October through September. The rates, when they change January 1. And so we're always spanning that year a little bit. And so we expect certain increases to those rates. The medical plan, dental and vision are zeros. The medical plan is a 6.5. That's not always going to be in line with the percent changes that you see in the upper left because the rates are relative to what was budgeted, specific to those plans. And so those are not always aligned with how the budget shows up specific to finance. And so just be clear about that. And so you were looking at a 6.5% increase to the rates. If we were looking at employees taking on an equal share, they'd be looking at a 6.5% increase to their contributions on the medical plan, but no change to the vision or the dental plans. That would still equate out to about the 5.3% overall increase when you blend those for those employees. So go on to next.
All right. Yeah, so that's our starting point. Wanted to kind of transition here to, okay, what do we do about that? What do we want to do? What's going on in the market? The transition for employers coming out of COVID, industry trends. We've all heard of the tight labor market. And so the prevailing trend right now is that employers are trying not to make any benefit changes or employee contribution changes. That seems to be the predominant trend. If cost mitigation is needed and critical, and you need to change employee contributions, one consideration would be a salary-based contribution adjustment where actually higher income earners pay a little more than the lower income earners. So that's going to be a trend. One of the biggest ongoing trends is going to be aggressive prescription drug management. Okay, and there's multiple ways to do that. There's within regents, for example, if we stayed with their PBM, we can go with more aggressive formularies, okay, which limits the amount of drugs within that are preferred. Most of the savings, more savings, can be achieved by actually carving out the prescription drug program to a different vendor. And that's becoming more and more popular. We'll talk about that more here in a second. And then, of course, an emphasis on member education and engagement in their prescription drug plan. This is a very sensitive area with people with prescription drugs, right? So whenever you intrude in this area, there's going to be noise and feedback. But with proper education, they can get accustomed to it. There's also a major emphasis on mental health resources coming out of COVID. Obviously, a lot of stress, anxiety going on. And so we currently have very good resources in the plan. We've got MD Live behavioral telehealth, which is already included in the plan. There's no cost for that. We've also got the employee assistance plan, which gives a handful of free counseling sessions telephonically. There's no cost to that. Often the issue is employees just don't know the resources exist, and so we can help put together a mental health resource toolkit for the county that has all these resources, contact numbers, all in one spot, and I think we should make a big emphasis of that going forward. And then obviously for the more comprehensive mental health, drug and alcohol therapy needs, we've got the medical plan itself. So that there's a number of no-cost resources. You know, it's really, you don't know where to go at the time, you know, you need it. And it's always that crisis moment that's most critical. Who do I call? And so we really need to get that out at the forefront for people. And we'll make an emphasis on that. And then the last one is Medicare eligibility education. Just want to state up front, someone eligible for Medicare who's an active employee on the Kootenai health plan, this is not an attempt to force people off. You legally cannot do that, right? You don't force people off the group health plan on the Medicare. But there are often times where there's win-win situations for the member to be enrolled in Medicare in addition to or to the group health plan. So the key here that we can focus on is education. And there's Medicare disability situations especially where they might be in a better position if they were enrolled in full Medicare, and that's a win-win for the county too. Again, just a focus on education, so we were thinking maybe some seminars throughout the year where anyone who wants to come and learn more about Medicare can do so. We'll bring in a Medicare expert and talk about it all. So those are the prevailing trends. Let's go ahead and switch. I want to talk more about the PBM, Pharmacy Benefit Manager carve-out. So I think there's 60 or 70 major pharmacy benefit managers out there. There's predominantly 6 that have most of the market share. The insurance companies contract with these large PBMs for pricing and leverage and other services. But here's who controls most of the market. CVS Caremark, Cigna Express Scripts, Optum, Humana, MedImpact, Prime Therapeutics. Regents, our current PBM, is Prime Therapeutics. Okay? They have about 4% of the market share. There's an option that Alliant has worked with our size and strength. Go ahead to the next slide. It's through Optum. It's that third level there through one of the big ones. With prescription drugs, there is pricing of drugs, and then there's 1,000 layers of different ways, different middlemen, different price points. Everyone's getting their little piece, right? So there's huge opportunity to save when you've got people like our RX specialists who know what they're doing and can cut through some of that and provide big savings. And this, we did a reprice on Kootenai County's RX plan. And this is what we're looking at. Projected annual savings on a 12-month period, that's what we're showing there, is $368,000. Now, when we look at just the fiscal year, which is 75%, obviously, if we started January 1st, it's about $276,000 savings just to move the PBM. Now, the members don't see any copay difference. This just assumes equal to equal member cost shares, right? The biggest noise on this comes from those who might have to change to a different medication. Now, within every medication therapeutic class, there are equivalent drugs, okay? Still, even though they might be equal to equal, there's going to be noise, and the projected noise on that is 35 to 60 members who might need to change medications. There's also a continuity of therapy language option we can include that allow people over several months to get used to this, learn about it, and make that transition. So we can minimize that, but really the noise when you make this change, the first 2 or 3 months, it's a lot from those 35 to 60, but people get used to it, okay? And so it dies down after that 6 months. The it lowers the projected budget increase. The 3.8 I'm referencing was David's first number. Really, the change on any of those reference points that you want to look at, whether it's a 6 or 3.8 reference point, it's about 2.4%, okay, from whatever number we look at there that lowers the budget for this carve-out.
So that just as a reference point, that's 2.8, lowers it to 2.8% if you're to do it before you take into account employee contributions. If the employee contributions don't increase, it's 3.1%. So 2.8 or 3.1 versus where we were starting.
Nice. So we can bump that up to about 3% as a rough estimate that lowers the budget if we completely carve it out. So that would be from when we're looking at the major buttons to push. If we need cost mitigation, that would be the first place we'd look and ask you to consider. Just to touch on the pros and cons, and then we can kind of come back to some recommendations and then talk through these things. The pros to a pharmacy benefit management carve-out are immediate cost savings. There's big savings. And as we go forward year to year, the pharmacy benefit is going to be the biggest touch point that we're going to want to keep our eyes on. There are literally $1 million drugs that are coming on the market, and we need to have solid eyes on that each year as we go forward. Kind of digress a little bit too. Even if we stay with the Regents PBM, every January 1st they adjust their formulary. So there's always a little noise, even if we stay with Regents. But when we carve out, it's going to be some bigger noise. But there's immediate cost savings that are significant. When we have an external pharmacy benefit, we've got a dedicated pharmacy specialist team with their eyes on the market, looking at this and managing it. So it's more aggressive internal management, not necessarily that the employees are interacting with, but it's stronger ongoing management that sets us up well for where the market's going in the future. And a dedicated customer service team. Oftentimes when a member calls up Regents, they're getting a general customer service representative who may not know what options are, what alternatives are, how to make the best advice. With this, it's going to be an external customer service that's dedicated to pharmacy. Now, that brings up one of the cons. Now you've got two. You've got a medical customer service line and a pharmacy customer service line. So potentially some awkwardness there for the member that they've got different customer service members. We mentioned the noise. The out-of-pocket coordination, with technology these days, those data transfers between the PBM and Regents, who would still be the focal point of tracking out-of-pocket costs, they coordinate that pretty well. But with that coordination, there's always a chance of a little delay in coordinating out-of-pocket. And then from a case management standpoint, Regents is still, their folks inside are the case managers overseeing an ongoing case. So someone needs a surgery, gets a medication, 2 different touch points. You need someone coordinating both sides of that. A little bit of disruption there potentially, but this is becoming more and more common and seamless. So before I move on to recommendations, David, do you have anything to add on this?
No, the only thing I would say, and the reason that we looked at one primary option if you were considering making a change, is because of how much this saves compared to anything else that you would do. The equivalent savings, for example, if you were to change the deductible, would be to increase the deductible by $1,000. Right, so I can increase my deductible by $1,000 or change my PBM. That would be the more appealing option, and so that's really the primary focus, and only if the budget requires that you need to make a change.
And that's a great point. We've been in the industry a long time, and I remember when changing from $500 deductible or $600 to $800 would save you 5%, right? Well, now to David's point, to save 2 or 3% on the overall spend, you'd have to increase the deductible from $600 to $1,600, and so this is again, there will be noise, but if we can communicate the alternatives to the employees and the facts such as those, we've got to mitigate costs, but would you rather have a $1,600 deductible, or would you rather have the same RX copays with a little more intrusion on the pharmacy benefit? it's an easier spend. Or the alternative, the bigger direct savings, is looking at employee contributions, and the corresponding increase to employee contributions is a big number as well. So either way, the money's got to come from somewhere, and the most equal minimization of employee out-of-pocket costs comes with a PBM change.
Good. Okay.
So let's go ahead and switch to the next slide. So as we look at recommendations, again, I'm using the 3.8 as a reference here. If you'd like me to add those other touch points that David referenced, we can certainly do that here. And so you've got a full reference. But option 1 is no changes. And this we're looking at that tight labor market scenario where any changes are going to be tough right now. But recommendation would be no changes, and use those PBM savings now that we've got that documented proposal costs. We can use that as leverage with Regents, and last year they did come off quite a bit on their pricing. We can do the same. We're not going to get equal to equal. It's just we're not. But could we find 1% in there or 0.5%? I'm fairly confident we can. So that's one option. So stay with Regents PBM, make no changes, but negotiate stronger RX pricing. And I think it would be safe to lower the budget 1% on that. David, is that fair?
Yes.
Okay. And then option 2 would be that RX PBM carve out. Lowers it from 3.8 down to 1.4. Keep everything else the same. Or to David's point, if it's at the 6, we're lowering it to 3. And then, of course, emphasize mental health resources as we go forward. So that is our first glance at this and what we think are good options. We never say any increase is a good increase, but our starting point is below trend. So that's in our world pretty good news. And to see David's slide over the last 4 years that our trend has been very flat, that's very positive news as well. Because the projection is 6, 7, 8% per year on average trend.
Yes.
It's easy.
Oh, and it's happenstance that it coincides with when we came on board. Man, it's just chance. That is luck of the draw. Sometimes you don't get that lucky always, but
yeah. Okay. With that, do you have any questions or anything you'd like us to expand on?
Questions for Scott, for Dave, or
Not
Coco?
really. A great job as usual.
Ina, Michelle? So we discussed these when?
Right now.
Okay.
Right now. I'll go first. I'd rather have option 2 and not touch employee contribution this year, and take care of some savings with changing the RX and to those 8%. And that's just a projection of 8%. We don't know that it'll actually be that high of people affected, right?
it'll be that high.
Okay.
And it doesn't matter what PBM change you make, you're always going to impact people because you have preferred and non-preferred medications.
Okay.
And each PBM has their own set of preferred, non-preferred, and that's how they maximize the negotiated pricing down and the rebates. And so you just have some natural, any change is going to require that, whoever we move to. So I don't even need to look at the numbers to know it's going to be, that, I can do that for any client, it's going to be that number of people.
Okay.
Jill, you had a question?
Okay, you don't have a microphone by you,
mic?
so here's one up here.
Take us, yeah.
No. So just stand there
Yeah,
or
you'll
sit
be
down.
fine there.
Yeah. Yeah. Either one.
I came from a county, or I lived in a county that had a large military population, both active duty and retired. And speaking towards your encouraging people that qualify for Medicare, what the county did to save money on insurance was they put a program in place where if you opted out of the county medical insurance, you got $100 a month put into a Viva account, and it saved the county a fair amount of money. I don't know how effective that would be here, but I know you do have retired military and you do have people that qualify for Medicare. So maybe that's something to consider I know it's too late, but
Okay.
And Sylvie, is that an option for us? Because I thought I'd asked Darren at one point and he didn't necessarily say we could give a benefit to people who didn't take the medical.
Well, I think if we, and Dorothy can help with this as well, is if we're treating all employees similarly, so we may not just be able to carve out the Medicare eligible people, it may be anybody who hops out of our health insurance
Okay.
would get that, say, $100 a month. So it would be offered countywide. If you don't take our insurance, we're going to put $100 into your VIBA per month into your VIBA account. So as long as we're consistent, not saying this group gets it, this one doesn't.
And you
But
can't.
I can tell you from the perspective of military, we have a lot of military people here and they're not on our insurance.
Okay.
They're all staying on military benefits.
And then the issue you get is now you're paying them. The other thing I'd say, and that does work sometimes, in various settings, depending on what you have going on. The Medicare issues that would exist primarily with the plan, especially your plan, would be more on the spouse side than it is on the employee side. As Scott mentioned, in there, you can qualify for Medicare 3 different ways. You age into it, you have kidney failure, ESRD, or you qualify as disabled. And 4 to 5% of the working age U.S. population is disabled, qualify for Medicare and Social Security, and they're not on your plan as employees, but they're on your plan as spouses. And if I want the full meal deal of Medicare, so I want a nice supplement, I want Part D, all that, I'm going to spend about $350, $400 a month post-tax. It costs less than that to be on your plan as a spouse pre-tax. And so that's where you have the biggest costs that come in. And so if there was something that you were targeting to kind of mitigate that, it would be on the spouse side, either increasing cost or putting in a surcharge if you have other coverage available so that they don't take your plan. Those would be the strategies to put into place. And the biggest target, because there are dollars associated with that are pretty significant.
Okay. Bill?
I think that the second option is the right one this year.
I'm kind of thinking the same thing. Does that deal more with, maybe you can help out here, with generics? Is that what, go ahead.
That's a part of it. Yep. Yeah. There's currently we've set up a 3-tier where there's generic, preferred brand, non-preferred brand. There's the trend now is 6 tiers up front. So you've got preferred, non-preferred, generic, preferred, non-preferred brand, preferred, non-preferred specialty. So it actually gets up into 8 tiers. It can.
But if you're in the East Coast, it could be 20.
Yeah.
I mean,
But yeah, that's a part of it. Now, within that, there's formularies, which are in each category of those, you've got a certain set of drugs. And those formularies might be different depending upon different carrier contracts with the PBM, because there's rebates that also factor in that's where this is the biggest shell game you can ever imagine. And our specialists kind of cut through a lot of that, go to the basics, and come back with $368,000.
How do these different drugs, I don't know if it's a fair question, how do they differ by way of effectiveness?
Therapeutic effectiveness.
Okay.
yeah, they don't.
I'm sorry?
They don't.
Oh.
Right. So they're therapeutically equivalent, and that's the general meaning of transferring someone. Most of the people are not. Let me start by looking at the savings. So if there's $300-some thousand in savings, about $250,000 of that is in the price that's being paid for the medications and the rebates that are coming back, right? So it's just getting a better deal. About $50,000 of that is people moving, from one drug to another. That's going to be a little bit more cost effective with this specific PBM. And maybe those drugs weren't most cost effective, with the Regent's PBM. Very little of those are people moving from a brand to a generic, because most people who could be on generic are already on a generic. There's not that much of that. Mostly it's moving from a brand in a category to another brand in that same category. That's more cost effective. And so that's primarily what's driving it. And so if you go back in time, I'm going to hit names that people will recognize more easily. back before their generics for all the statins, there was Lipitor and Zocor, kind of dominated the marketplace. It'd be like the equivalent of saying someone needs to move from Lipitor to Zocor, or Zocor to Lipitor. It's that kind of change. It had the same effectiveness. The only difference is, on occasion, you are going to have someone who, for whatever reason, this drug does not work for me, or the side effects for this drug are too severe. And there are issues within the language of the PBM to handle those exceptions, when those occur. So that's what you have in there as the backstop for protection. Otherwise, the effectiveness should be the same.
Okay. Option 2. You got all 3.
Okay. Thank you very much.
This is too easy. Good job, guys, as usual.
Oh, well, thank you.
Any questions? And I see, yeah, go right ahead.
Okay, so if we go with option 2, what I'm hearing is that there's going to be some changes to the prescription benefits, but am I hearing correctly that there's going to be nothing passed on to the employee?
That is correct. That is correct.
No.
So the only, I'm not holding it to the, to the fire. I'm just asking, so I'm going to get asked. The basic thing here is that employees aren't going to have any more taken out of their paycheck. Your deductibles won't change, out of pocket won't change, but the prescription component will. And basically, that's just going to involve whether somebody gets a generic drug or a name brand.
Or change name brands. It may not just go from one to the other.
Right.
All right, thank you.
But it'll be the same category of drug, I think, as Scott just pointed out. So I think the answer to your question is yes.
Thank you.
Yep.
Even I get
Anything else? No other questions? Scott, did you want to? Sylvia?
I think we're good. I was just setting some conversation with David about communication, and we'll have plenty of time to communicate to the employees. That's the biggest thing on this as we go into it.
Well, it's why we need, it's almost why we need the answer now. Because if we're going to do this, there's a lot of work to make that transition happen on January 1. And the PBM will reach out to some people specifically who are on higher cost medications that there might be a change. And then there will be other communications that will occur. So just,
your choice of the word noise.
Yeah.
right.
That's probably an accurate representation.
Oh,
You want to silence the noise as much as you can. So
you want to, but you want to, I mean, I would tell everyone to definitely expect it, because you don't make changes like this without noise. But the noise is less than, like you said, if you made $1,000 deductible change, everyone is going to go, what? Whereas on the PBM, there's just certain people on the medication and everyone else is unaffected.
Okay. Anyone else? Any other questions? Public comment? Okay, so the time is now 1:35. Meeting is adjourned. Thank you, Alliant,
Thank you.
as always.